Okay, and I keep this. Oh, I have a pocket. I don't usually have a pocket. All right, and tell me again.
Just that. You just click that mouse button.
And is there a laser?
Yeah, it might not go backwards, but.
Oh, it has to go backwards.
Okay. Back, yep.
Yeah. Yeah, I have to start at the beginning. All right, and then the lights. Lights?
They might need a break in about 45 minutes.
Okay.
For about 10 minutes.
And you'll get the lights?
I can do the lights, yes.
I do have lots of images, so deep, dark is good.
Is that better?
I think so.
Is that okay, guys?
Yes, two-time alumni. I became a nurse practitioner in 1990. So, but then I stayed home with my 3 boys and came back in the field, and voila, I found out that serendipitously that older people have a hard time doing their own foot care, and that gets harder and more difficult as they get older. I brought with me, I've been doing this for 10 years and seen thousands and thousands of feet and done foot care, and collected many photographs, thousands of photographs. And so I just selected a few here. I remember, or just even current presentations, people will oftentimes show you the worst case scenario on the, like the worst ulcer they could find or whatever. These are not the worst case scenarios. These are like everyday things. And Carrie is right. If you take 100 people over 65, you will find 25% of them have an acute problem. So you're going to find problems, and hopefully this will help you. Hopefully help you identify some of those problems. Now I'm cooling down. All right. And so I always like to start out with saying there's a critical need for nurses knowledgeable in foot care to do assessments and interventions into the unmet needs of their patients. Most of your patients will have unmet needs because we don't even know that they have a need. We don't take off their shoes and socks. But there is a critical need for nurses to be knowledgeable, and if not knowledgeable, to actually develop a skill in foot care. Currently in this region, there is not a podiatrist or hospital that does routine diabetic foot care for Medicaid patients. That's it. So I see most of them at a reduced fee, but there is no Medicaid provider for that. And Medicare providers are even, they're starting to do a little bit of foot care. 10 years ago, their foot care was guaranteed almost for every healthy elderly person, but that went away and hopefully will eventually come back. Research does indicate that they have difficulty performing foot care, and we're going to talk about why. And it's going to be interactive. I might ask you some questions along the way, or if you have a question. And they have problems obtaining routine foot care services. Foot care is an unrecognized medical need. There are foot problems that are almost unavoidable in the elderly if they do not seek care. And evidence demonstrates that you are putting them at risk. We are putting them at risk by not answering and assessing their foot care needs. And this is related to the fact that inadequate, unsafe, neglected foot care can have significant sequela, serious sequela. So I thought we'd start off by actually defining what foot care is. So I'm going to ask you guys to tell me, when you're told you need to do foot care, what does that mean? What might it, if it's just one thing or 2 things or 3 things, what things might come to mind when we think, what is foot care? Trimming toenails. Cleaning
Between the toes.
Yeah, that's often neglected. Go ahead.
Right size shoes. Right shoes.
Yes. Oh, you guys are going to be great. So it's a lot of things. First of all, foot care is an ADL. It's not often thought of as an ADL, activity of daily living, because if the ADL isn't performed, there is deleterious consequences. And it does affect quality of life. We'll go into all of that. So it's foot hygiene. It's daily cleansing, drying, moisturizing, nail and callus care. It's daily. We don't always need to trim our toenails every day, but we certainly do routinely every couple months or more often to make it easier if you did it weekly. Monitor and respond. Foot care is also, we need to, a person needs to be able to inspect their feet to see if there are any changes, any problems. They need to be able to respond to those problems. A diabetic elderly, if they see a sore on their foot, they need to be able to see the sore or have a dependent other be able to see their sore. Otherwise, they may not feel that sore, and it becomes a more serious complication. And then if you are high risk, whether it's diabetes or any other problem, you need to be able to do those daily inspections. You have to check your feet every day. So that they need to be able to do foot hygiene. They need on their own, or someone needs to do that. Monitor and respond to problems, and then make informed decisions. Getting the right shoes. You know, most of the time they do not wear the right size shoes. Feet grow about up to 2.5 sizes as we get older. Everything kind of spreads out. And so they oftentimes are looking for fashion or whatever. They don't want to buy a new pair of shoes. It's a hassle to get out. It's uncomfortable to get out and shop for shoes. So they end up wearing shoes that are too small and too narrow. That causes problems we'll talk about. And then protective sock wear, you know, wearing if they need compression sock wear so that to control their swelling in your legs. They need to be, that is all the definition of foot care. And that's how they think of it. They think of it as difficult exercise. So I'm going to ask you again, what might some of the self-care barriers be? So if someone can't do their own foot care, what might the reason be? Go ahead, yeah. They cannot reach. And so why might they not be able to reach? What are some reasons? Obesity, abdominal obesity. And that starts sometimes way before. It starts in their 30s, 40s. Well, teenagers. I have teenagers who are in my clinic who cannot reach their feet because of obesity. What else? What is it? You mean they just can't reach like they have arthritis, they have shoulder problems, hip problems, knee problems. Even if it got repaired, they don't have that reach. Yeah, they may not have the right state of mind or know that they need to. COPD, you know, or congestive heart failure, can any of those people reach their feet very easily? Parkinson's disease. Parkinson's is really common. You get a lot of rigidity in Parkinson's. And just a little side note, I have patients who if they don't know about this program with the physical therapy department out at Peachtree, the boxing program, I forgot the name of it. It's not the boxing program, but Parkinson's patients box. They don't box each other, but they box a ball. And I guess it's called a ball. And so you know what I mean. So I had a patient in 6 months' time develop an increased reach of 7 inches just by staying active, which is amazing. You know, a lot of times they think they have Parkinson's, they have, you know, decompensation. They just quit trying to reach, to stretch. But yeah, those are all MS, stroke, all those people. If you look at a person and you see any of these characteristics, that should tell you that they can't do their own foot care if they can't reach. And that means they can't even bathe routinely. So you can imagine what that web space looks like. You know, if they cannot routinely bathe between their toes because they can't reach their toes. It's a problem. So reach is one. What's another? What do you need to be able to have to do your own foot care? And this could be your grandparents too, so there are applications towards all this. What else do we need? We need to be able to reach. Yeah, you do have to have supplies. You have to be able to, you know, a lot of people have those clippers, but we use nippers because they're so thick. The nails are very thin. And so most people will tell you that they can't even get the right equipment to do their own foot care. It's not really sold, and now the pharmacies are starting to sell it more because I'm telling them to, but when I first started doing this, there were no appropriate nippers. Even at Sally Beauty Supply, they're all cuticle nippers. So yes, what else? They need to be able to see. They need to have the vision. Visual impairment is a real big problem, whether it's a diabetic elderly with retinopathy, macular degeneration, all those things. If you can't see what you're going for, then what's going to happen next? You may end up cutting yourself. And that's true. I have at least 3 patients over the years who have told me that they ended up in the emergency room because they're taking their blood thinner, their Coumadin, their even enteric-coated baby aspirin. And if you are going to one nail and you nip the skin next door, then you have to be able to stop that bleeding if you even knew that you did that. If you have no sensation, you can't feel, you don't even know that you cut yourself. So it's very complicated. Most of these things, even if you have the tools, you need to have more than one factor going. You need to be able to reach and see and you have to have a lot of those need to come together. So, that's a lot as we get 60, 70, 80, certainly in our 80s and they're more frail. If you're sent in to assess an 80-year-old at a long-term care facility and you don't ask them to take off their shoes and socks, let this be a reminder that an 80-year-old probably cannot get to their feet. And so we'll see what the consequences of that is. So there are consequences if you can't. It seems simple. Hygiene seems so simple. But until you've actually, like a lot of my patients have told me, I never thought I'd get to the day when I couldn't trim my own toenails. They are very embarrassed by that. So unsafe practices, we talked about how you can, actually accidentally cut yourself. A lot of times they'll bring out razor blades to trim their own because they don't have the proper, callus removal. So they'll do that. They have a diminished sense of well-being. It's like it's a helplessness. They feel helpless if they can't get to their own feet. And plus, it's an embarrassment. So if it's been 6 months or a year and you haven't had any foot care, then it's very embarrassing, and they really don't ask anybody. They'd rather keep their shoes and socks on. And it's isolation. We're going to learn here in just a bit that if you have pain when you walk to go to the mall to buy a new pair of shoes, then you become socially isolated when you can't do your own foot care. And we're going to find out a lot more about why that is in detail. They're at risk for a lot of infections. We'll go into detail about that, ulcers and amputations. They have a lot of discomfort and pain and falls. So we're going to kind of go over all these general categories of the consequences of not getting routine foot care or talking to someone about how to take care of their feet. Remember, wearing the right size shoes and getting the appropriate footwear is part of foot care. I wondered about that. I don't know why. It was actually supposed to come up one at a time, so I thought, what's going on here? Oh, you probably want this. I'm technologically forward. Yeah. Okay, so kind of a good way we can kind of organize our thoughts about this is one section of this is to look at falls because it kind of encompasses a lot of areas. And foot-related falls in the elderly. There are important documents by the British Geriatric and American Geriatric Associations who talk about addressing foot care needs, but oftentimes those aren't assessed except for in the sense of unsafe footwear, so not having traction. There are a lot of other foot-related falls that we can actually catch ahead of time. So first one we'll talk about is foot pain, and that leads to falls. It affects at least one to, these numbers are probably like under represented. It's probably more than that, and certainly in their lifetime. 1 in 4. Foot pain is debilitating. It's the main reason not getting out, not exercising, not going to the mall, just to socialize or get their basic needs. It's harder to get their ADLs done. They end up having a very sedentary lifestyle. Their muscles atrophy because they're just not getting enough exercise for them, and then they aren't physically active, and that is very debilitating. When they walk, if you have foot pain from pretty much any source, whether it's a stress fracture or a corn or a thick nails, your walking confidence is going to slow down. You're not going to be as confident, and your gait and your speed is going to go down. Your gait is going to be changed, and it's the reason your gait is changed when you have foot pain is that you're trying to alleviate the painful side. So you're trying not to walk on the painful spot. And if you imagine your 75-year-old or 80-year-old patient trying to not walk, or maybe even scooting to walk because it's not as painful, that contributes to falls. It's actually an independent risk factor for falls. And then, of course, the balance is impaired. Independent risk factor. So let's talk a little bit about what can cause the discomfort and pain. And the things that cause the discomfort and pain in older people is the aging problems. And it's the aging process as well as things that happen along the way. Fractures, surgeries, developing diabetes, developing psoriasis, all those contribute, but are common aging problems. We see them in the aging. They get thick, misshaped nails, and this can be a lot of shapes. It can be thick and dystrophic because of fungus, nail fungus like onychomycosis, or it can be, some have like strange shaped nails because their aunt or their mother had pincer nails or any number of types of nails. So they have that. They have corns and calluses. As we get older, our skin, it gets drier. The oils are gone. The sweat glands don't produce as much and becomes drier. And then you have certain problems that the thyroid disease that can contribute to the dryness. Obesity is another. A lot of people, I see a lot of heel calluses, heel fissures. It's because of obesity, but oftentimes they're not wearing shoes that have a back so that their skin is exposed and it becomes even drier. But that's painful. If you've ever had fissured heels and walked on them, it is uncomfortable. They develop muscle atrophy, which can cause pain. If you're used to walking across the room and then you have to walk to the doctor's office, you get tired, you can develop foot pain. They also get ligament laxity, and lots of times that would involve even having heel pain, instability with their ankles, and maybe a sprained ankle because of that. The ligaments get longer, and they also develop, their shoe size gets larger, so lots of laxity problems. Fat pad displacement. So we all pretty much, to some degree, have a fat pad at the ball of your foot, the metatarsal heads, and also in the heel. The bones are right there, the joints are right there, and so it's a nice natural padding to prevent pain. And as we get older, that doesn't atrophy, it just splays out and gets flatter. Some people, you can look at the bottom of their feet, and it's just bone. There's barely any kind connective tissue or fat there at all. And that's very uncomfortable to walk on. And of course, they can have joint abnormalities. They can have a fracture from osteoarthritis, degenerative joint disease, rheumatoid arthritis. They get with RA, they get huge fusions in their joints. They can have a bone spur or a bony growth on where their joint is, and then on the skin, how it appears is like a callus. It becomes a really thick, painful callus. So if we look at this guy, what do we notice? Well, they're thick, they're yellow, but he's dry, and he's got this guttering here, and that's atrophy. So he's got atrophy. We also notice that is cutting into that. You can't really see it, but if you put your shoes on, you can imagine how uncomfortable that would be. This is not uncommon if you were to take the shoes off. This was a very active woman who she was seeing her doctor probably every month, and no one ever asked her to take off her shoes and socks. She never complained, but you can see her atrophy here. You can also see this dryness. It looks more like an ischemic dryness, really no blood flow. That's a ram's horn toenail deformity. Ram's horn is also called onychogryphosis, and it's very thick, abnormally shaped. Usually there are ridges in there. You can see the ridges, and then it usually curves over. That's ram's horn. It's actually not uncommon. But anyway, if she had, and then after I took that picture, and her husband was the same way. I didn't take a picture of his. It's like, wow, I'm going to have to start photographing this family. But she saw me for 5 years before she passed away, every 2 months, because she didn't have access, and then she did. I went to her retirement facility. But anyway, that's not uncommon. This is a lady who, amazingly enough, her daughter is a nurse practitioner, and she said, I just went to visit my mom. Can you see what's going on here? I mean, she's got this and this and this, but this one's going over how long it's stabbing into the first one. So she had been in a facility here, a very very nice memory care facility, and she discovered her mom's feet when she was showering, had walked in, and the excuse of the person in charge was that the family hadn't signed a release for the podiatrist to come. And so, I don't know if you were the DON who I showed that picture to and said, look what's on your floor, I would be upset that I was taking care of someone and I didn't know how bad her nails were. She was dementia, but she walked around all the time, really skinny, walked around all the time. So she just had, it's just kind of grotesque when you think about that. She had good medical care. So this is another lady. If you're walking with this stuff, you can see her calluses here and here. Those are actually blood underneath there. They're hemorrhagic calluses, and we'll talk about hemorrhagic calluses in a little bit. But if they have sensation, that's going to be very painful. But I made her better. And you can, I was going to say, when their toes kind of curl around like that, they're not made to really walk on that spot, so they callus up even faster. And there's another, that's what I do basically is take that, and that could be a ram's horn onychogryphosis if it were allowed to grow out more. And so you can see the ridges in it. The ridges are actually, there are lines, Bowes lines, that actually can tell you that this person probably had an illness. Like it's when the matrix, when your nails grow, they grow out this way. And the matrix is where the cells start. And so if they become ill, then the growth of the nail is going to stop. When they get better, 6 months later or after their fever, then it will start growing again. And those are the horizontal ridges that you see oftentimes in the elderly. And you can see that. You can also see, these aren't that thick, really. They just are, they've kind of soft enough that they curl under, and you can see the indentation here. We're just now talking about painful conditions from lack of foot care in ordinary people. There's another one. She can't get to her nails. She didn't know where to go. Medicare doesn't do foot care anymore. So, in fact, at MOI, Missouri Orthopedics, they don't do routine foot care for anyone anymore. So there's only 2 places in town besides the VA. The private practice, Columbia Podiatry, and me. That's it. For a big region, it's kind of amazing. And so if you have a patient, you could easily do his foot care for him, but he couldn't. That caused, when they're that long and they've got their shoes on, oftentimes they'll have, and we'll see one of them, I just put one slide in. Well, you can see it actually right here. There's ecchymosis there because this is pushing that way, and you get an ecchymosis. You get that bruising right there. So this is a lady who, actually I got a call from the urgent care. And this is the 4th day she was on Keflex. So this is the 4th day he was treating her for cellulitis. I don't know what this is. I've never seen, but it's a white fungus. I've actually never seen that. But she is a 91-year-old. You know her. I mean, she's vibrant. The daughter called me and said, I cannot believe that and the reason she didn't know she had poor vision and she had poor sensation. So she didn't see what this nail here, this nail is this nail, and that is what's causing the cellulitis. You have all this wound and all that redness, and that's the 4th day, so she probably looked much worse. But the daughter, who is actually a nurse and who actually should know better because she knows about foot care, she didn't ask her mother-in-law if she's getting her toenails done regularly. So what we do is file the nail down and treat the wound. But, the urgent care could have done that. But so that's a breakdown in the step process. They really could have done that. And I get lots of wound care patients who really, the wound care nurse could have done these, but they're afraid to. So that's why you guys can build your repertoire. They are afraid. I had a DNP student who was with me for 75 hours last semester, and he'd been a wound care nurse for, Paul, been a wound care nurse for, 30 years. And he came to me and wanted me to teach him how to do foot care. They were afraid to do it because of the diabetes. It's like, oh my God, it's just the opposite. They need foot care because they have diabetes. But anyway, and something even as simple as this, where they have thick nails, they're very just, they have a lot of hyperkeratosis here. You can kind of see it. But you can see this is cutting into here. So if somebody says, my toe really hurts, and you can't really see, well, you just move it around a little bit, and you can see it's really cutting in there. That's painful. All these things are very painful conditions unless you're insensate, and then you have a second problem if you're insensate. But it doesn't just because you're insensate does not stop the damage. It's still like that lady and then cellulitis. And there's a lot of weird shapes out there. So, I mean, that's pretty deep. As you can tell, that's pretty deep. But it felt a lot better after I got done. And there's the ecchymosis I was talking about. When they have long nails, that's hitting the front of their shoe and it's causing bruising. This is a little bit more serious condition where it causes bruising. You can see, I didn't think about this when I started, but you can see how dark this is there. And you can see how thick it is, actually. And when you debride that down, there's a lot of blood from impact, but there's also it's this white here, and that white looks a lot like a pre-ulcerative lesion. And it's really, you can see why an ulcer would form. You've got this thick nail with impact going down, plus you've got the shoe coming down on it. There's a lot going on, and with the elderly, they don't heal fast at all. Their healing is slowed down quite a bit, and that's just for a normal aging process. Then you add any other kind of comorbid condition that they have. You can see how thick these nails can get. When you debride that down, I mean, you can see how much pressure there is. And the nail doesn't look too bad until you see that it's infected, because there's nail fragments probably causing that. And they get a lot of, it's dry, hyperkeratotic. It just breaks off easily and can easily cut into the side of their nail. And it's not really an ingrown nail, but it might be. So the thing you do is you take a nipper, a sharp nipper, and you just cut the offending. If you've done that, you've helped them. And it's not brain science. It's not brain surgery, really. It's just getting rid of the offending, what's causing the problem. This is extremely common. I see it a lot where, their nail is going backwards. Their callus is, because they're walking on that. And you can see why that would be painful, but all better now, right? That's why it's so rewarding. It would take me 7 minutes tops to do, 10 minutes to do both feet. And that's why it's so rewarding, I mean, it's a skill. People love you for it. And you can see right here, we haven't talked about this yet, but you can see I would call that claw toes. I mean, you've heard of hammer toes. We'll see them in a little bit. I would say that's claw toes. And it's very common, and it's a really serious condition when you have someone with diabetes or insensate for other reasons, and they're walking on this. This is where an ulcer is going to develop. And you can see, when I took it down, you can see where it's bloody. That's a pre-hemorrhage callus or a hemorrhagic callus or a pre-ulcerative condition, okay? And if they didn't get off their feet, continue to walk on it, then that would end up being an ulceration and then an amputation, which is very common in the elderly. This is another reason why it's painful to walk. That's a callus. You can kind of see her toes are also hammer-toed. This toe is sticking straight up, which pushes it down. And this joint here, the angle's kind of funny, but it's the second metatarsal joint, and it's pushing down, causing that callus because it's trying to protect it. But it's developed into a pretty thick callus. File it down, and it's a lot better. It's not perfect, but it's a lot better, and you can still see the hemorrhage underneath that too. Corns are, you can get them, sorry about the blurriness. You can get them on the toes. Corns usually mean a callus on the toes. So you can have a dorsal corn on the tip, and it's always over a bony spot because it's the bone and friction and pressure onto the bone. The skin is trying to build up protection. So you get the callus. So you can get them on the dorsal side. You can get them in between. I think that's where we look at that now. In between, and you can see this one after I removed it. But that's when the toes are held close together, usually by either a severe hammer toe or shoes that are squeezing them together. And so that develops into a corn or a soft corn because it's moist in between the toes. It's all really callosity. It's all calluses, but the lay terms are corns and soft corns. And then you can also, there's a corn. I kind of enlarge these too much. There's another corn. Look at the condition of the skin. It's not really a great setup for getting a corn. That's going to turn into an ulcer. This is a diabetic that's shoe. So you have not just the callus or corn, but you also have an infected toe because of that. We also have calluses. People, you can see this guy really, he doesn't have much fat pad. That's just like a flattened surface. But he's got a callus there, and this guy's got a callus here. Those are also very painful. Like I said, we see a lot of heel fissures, especially in the obese. They cannot get to their feet to do the care. They're obese, so they end up fissuring out. So ordinarily, if you have a heel, dryness, callus, and then fissures, ordinarily, you do a couple things. One, you always apply emollient every day. But before you apply emollient, you have a nice, coarse, thick file. File it down dry, and then put your emollient in, like even Vaseline works. And but if you can't reach your feet, so this is a elderly gentleman who had, I can't remember what type of cancer he had. He had very thick lymphedema. But the other thing you can tell people is a heel cup, and not to go barefoot or wear shoes that don't put their heel in. A heel cup will kind of push it all in to get back together so it's not splaying out. But that's a good spot for infection to get in, and it's also very painful. We can make them better very quickly. It only takes a couple minutes to file that down, put an emollient in. Foot pain in the elderly, we see that also with inappropriate footwear, which I've alluded to. It's not just the length, but it's also the width and the depth. If they have hammer toes, they need to have an extra depth shoe. And so if they don't, then they get those corns you saw, or worse. And if the length isn't right, that actually contributes to a hammer toe condition, so that their toes kind of get squished in there, and so they actually develop into a rigid contraction. But she had a unique, answer to her growing feet. She couldn't afford her shoes. These are actually diabetic shoes, so I thought that was unique, but it obviously is not enough. You have to do more than that. The other thing you can get when you have shoes that are too narrow, people, especially women, it's called, quote, Morton's neuroma. But what it is like carpal tunnel, where you have nerves going in between the metatarsals, your bones. And if you squish those together, then you get an entrapment, kind of like carpal tunnel. You get a nerve pain. And it often leads to surgery, but really the most they need is appropriate footwear. So, yeah, we see it all the time. She's 94. Well, every time she came to see me, look, she's got because she's shorter now, her slacks, rolled up. Not a good thing if you want to avoid falls. High heels, but that was the generation. But you can see how, it really has, there's a seam in there, it looks like. So appropriate footwear, if they have foot pain, you really need to look at their feet. And this is kind of what it looks like. So you have shoes that aren't the right length. You get callus at the bottom, at the ball of the foot, the first metatarsal head. You get a corn on the top. And the thing that they leave out on this, and I can't believe they do, is that you get a callus on the apical portion of the toe. And we see that especially with diabetics all the time that lose their toe, is that they are developing a callus at that apex of the toe. So if you're telling someone that we don't want toes together, we don't want, I don't know what that's supposed to be depicting, but this is not, there's not a space there and not a space there. We need a thumb's width from the longest toe, and we need to be able to wiggle our toes and have space in between. If someone is insensate and can't feel, they're not going to be able to help you very much in fitting their shoes. They, of course, get a specialist. And this is exactly what happened. He's my patient and said, you're due for your new therapeutic footwear. They get them once a year. And I said, have you seen your feet? He came back, I got my new shoes. Well, I said, have you seen your feet? And he can't see very well. So I always take pictures, not just for me and educational purposes, but also for my patients. they can't see what you're talking about. 80% of the time, they have no idea what their feet look like until you show them on your phone. And I'm not saying that you guys are, I don't know if you can do that, but if you delete it right away, nobody will know. But they don't know. And so these, if he hadn't gone in and we hadn't discovered this, those would develop into an ulceration, cellulitis, and osteo by the time he would even feel it. I always try to show people, yes, your shoes are too short. You're developing a callus. This person's right foot is longer than the left. You can see a little bit of callus there, but a lot of bit of callus here. It's just because they're rubbing friction and pressure at the tip of their toe. And some people will not believe you until they see. That is evidence. Second toes are a big problem. It's very common. You can see that is hemorrhagic there. It's not so much there. That's more of a corn. If you looked at that, I would say that was a subungual corn, a corn underneath the nail, just from friction and pressure. But this is bleeding also. So when we look at people's toe links, a lot of people who have this problem here, their second toe is larger than their first. I see they oftentimes will have, at the most benign, they have thick toenails on the second toenails. They don't, it's not, oh, they think it must be fungus. It's not fungus. If you don't have it in your big toe, it's probably not fungus. It always starts there, it seems. But they have thick toenails on the second toes, and they have longer toenails, or toes. And so this is what ends up happening is, at the most worst case scenario, is you can even see how this is trying to go back even with this. You can see it's bumped out. It's a hammer toe. But this, she lost her toe. I told her, you cannot keep, you've got to get longer shoes. And she ended up losing her toe. So we look at toe and foot deformities is causing falls in the elderly. They get pain, they get postural instability, and that's particularly true with hallux valgus, which is bunions, big toe bunions. They get gait changes because there's structural integrity from the deformities. The ligaments are kind of going a different way, and then their muscles atrophy because they're not using them the way they were, with normal structure. They have diminished walking confidence. So here is a bunion. Bunions are usually a hereditary condition. Sometimes when a bunion is fixed surgically, they end up with this. This is hallux valgus, gum. So when it's gum, they're kind of stuck together. So if you put the feet together, they're kind of stuck. Hallux varus is the opposite direction we see sometimes with failed bunion deformity. But what happens in a bunion is that it's a toe deformity that causes the metatarsal bone to, instead of going straight like this, it goes out. And the joint becomes hypermobile, meaning that this metatarsal goes out and the phalange goes in, so that it's kind of creating a little bump out, a bony prominence. But it's just because it's hypermobile and it's just separating at that spot. And that's basically, really the only thing you can do with that besides surgery is, they go from mild to severe. They can be pretty severe, and the more severe, the more likely there is to fall. They don't have a lot of stability when they're walking. But is to wear good supportive footwear, insoles. And there's a little bit of a bunion. Looks like that almost got repaired. But you can see everything kind of squished together. It doesn't. This is a bunion here. It causes, with bunions, you end up having overlapping toes, underlapping toes. This is kind of like one big happy family trying to get close together. You end up, you can't see the bunion there. I'm sorry, I left that out. But these get squeezed together. This one gets popped out. It's just trying to make room for the deformity within the shoe, because the shoe, usually people buy the same shape all the time throughout their years. And so they end up with deformities. Their feet and toes have the deformities based on their own structural hereditary problems, but it's also the shoes that they're wearing help form their deformity. So here's a hammer toe and claw toe. I think of hammer toes as being something that's caused by environment or heredity. So wearing the improper shoe, that causes that contracture there. And then claw toes are more because of a disease, a central nervous system disease, a peripheral nervous system disease, stroke, diabetes, neuropathy. All those cause claw toes. And this is what happens. You know, you have your ligaments, and so your extensors and flexors, these start getting, and this is particularly true in diabetes, these start tightening, these start loosening, and then the contraction forms. So it's that imbalance that causes it. And you can see these are planted, their toe pads planted down, and that is a claw toe deformity. Causes pain when they're sensate, causes walking instability, and can cause development of ulcerations. And there you can see the hammer toeing, because they're trying to they probably bought shoes that, look how dry that skin is. And this looks like it's green underneath. So if it is green, then it's most likely Pseudomonas, because their nail has lysed. It's not really attached to the nail bed. And so if they have a constant moisture situation, then they will grow Pseudomonas underneath there. And you can just have them soak their feet in vinegar, which is a great cure for Pseudomonas. It happens with nails. Women get nail gel or whatever, fake nails. I don't know what. They get Pseudomonas sometimes under those because of the moisture getting trapped. Or, workers get, like if they wash dishes and they don't wear gloves, constant moisture can cause a Pseudomonas growth. So the other thing contributing to falls is unsafe footwear, and we always have to talk about that. And what makes something unsafe? Well, when you look and see who falls and who doesn't fall, fallers will usually in their home, if they're doing it in their home, they're wearing socks, slippers, or going barefoot. People, when you compare fallers to non-fallers. So what the features of a safe footwear selection, besides just therapeutic versus not, just the mechanisms on it are, and you will see this a lot. But to me, it's one of the most important besides traction. You got to have good traction, slip resistance. But you'll see people, I know you've seen it 100 times, where they don't tie their shoes or they barely tie them. They're not fastened. So we don't want anything tight right here in the forefoot, but we want this nice and snug. Now, they don't want to do that because they can't get them off. It takes them forever to get their shoes and socks off. But to be a non-faller, you really have to have that fastening mechanism, whether it's Velcro, whether it is shoelaces or a buckle. That keeps it safe and keeps the ligaments from keeps them snug in posture. And then also having low heel height. That's especially true with Parkinson's disease. They don't really pick up their feet as much, so the lower heel possible. And a good stiff heel back. They call it the collar. Some people wear really great shoes. Their families have gotten really great shoes. They've put out a little money and got really good, safe shoes. And sometimes it's just not the case. Okay, so diabetic. So we got, what number are we on? I think we're doing okay. So it's not really talked about much, but diabetic elderly fall. They are big fallers. They have many reasons for falling. Diabetes is a significant risk factor for falls, 40% annually, and diabetic fallers are more likely to have recurrent falls. Sorry. They are physically vulnerable. They have sensory neuropathies, or why they fall. They have sensory neuropathy. Does anybody know what sensory neuropathy is? Have you gotten that yet? We're going to define it here in a little bit. And medications. There are multiple medications, and their footwear. So why are they physically vulnerable? They have, diabetic elderly have, they have diminished range of motion in their big toe and their ankle. They have diminished strength because and atrophy. They have diminished strength sometimes because the neuropathy will cause them to have motor neuropathy and causes weakness. They have muscle atrophy from not being active. They have lots of joint swelling and joint pressure swelling. They're obese. They have a lot of cognitive impairment, sometimes depression, and they lead a sedentary lifestyle that makes them physically vulnerable for a fall. Sensory neuropathy, they have a 50% loss of sensation. 50% of diabetics have a loss of sensation, protective sensation. When you bend their toe, they don't know, they have a position sense diminished where they don't know if their toe's pointing up or down, and they have a neuropathic gait because they can't feel, and they have poor postural control. So a sensory neuropathy is, well, we'll talk about that in a little bit, but what happens is they have diminished feeling. So if you were to touch their toe, or if they were to step on a tack, or if they were to stub their toe or have an infection, they may not be able to see it. The longer they've had their neuropathy, the more progressive it is, and it takes more and more pressure to feel that pain. There are multiple medications. You know, the blood sugar is going up and down all the time. They're on pain meds and maybe on gabapentin or some other kind of psychotropic pain medication that causes also just sedation. And then they may have an ulcer. They may have and need to wear a cast. They may be an amputee and have prosthesis, sorry. Or they may have AFO, which is ankle foot, orthotic, which is a brace that helps them from foot drop. A lot of times diabetics will get foot drop. So there's a lot going on that could cause them to fall. All right, it's 2:30. This might be a good place to stop. They get a 5-minute break?
Yep, they can have a break.
Oh, I thought they did. So 5 minutes? The good stuff's coming. I know I'm.
All right, we're back, everybody.
All right. So we're through with the calluses and the corns and the fissures and all that. Now we're going to go to infections in the elderly, foot-related infections in the elderly. So what factors in the host, in the person, might increase someone's chance for infection? Kind of basic, but what might increase their chance for an infection? Yep. Yeah, host factors. What in them, what medical history might they have? Or social history? Or did you have? Diabetes, very common. Low immune system, if they've gotten treated for cancer recently. Our elderly, you will be seeing, oftentimes they're getting treatment for cancer. They're getting chemotherapy, radiation. They have diminished immune system. Okay, so B12 deficiency, HIV, all of those. Why are the elderly increased with? What comorbidities? Well, I think we just answered that. What infections are commonly developed? So that's what we're going to look at. So the common comorbidities for people who have increased risk for infection are diabetes, peripheral arteries. So why would, do you know what peripheral artery disease is? Somebody? Peripheral artery disease, peripheral vascular disease. That's where the blood flow, so cardiovascular disease, you have heart disease, and then peripheral vascular disease, you have disease of the blood vessels, cholesterol buildup going down to the legs, the feet. Also carotid artery, they get peripheral artery disease is where their carotid artery gets clogged up, and then they have stroke, and then abdominal aorta, and they get aneurysms. So that's all peripheral vascular disease. So how would peripheral artery disease increase the risk for infection? Well, if you don't have blood flow to the area, then you don't have the nutrition, the oxygen, nutritional factors getting down to that area. So that increases the healing time. They can't heal quickly, and so it increases the chance for infection. Make sense? Cancer therapy, nutritional, HIV. What infections happen? Well, onychomycosis is nail fungus. It's very common. At least 50% of individuals over 70 have nail fungus. Onychomycosis. They also have athlete's foot, tinea pedis, and there are a couple different types we'll look at. They have bacterial and yeast infections, especially with diabetes, cellulitis, and of course they have wound infections. If you have an ulcer on your foot and it's not treated within a month, it's going to be infected. And oftentimes they don't get adequate treatment for their ulcerations. So this is a lady who had just got finished chemotherapy. When she walked through the room into my office, it didn't look like that. There was a nail there. I didn't do it before and after, but I could smell her infection. She had her nail, you can see how it's really not attached there. I don't know if you can tell, but it's called lysis when the nail does not attach to the nail bed. Many reasons for it. Trauma is one. Chemotherapy is another common reason that we have nail lysis. It separates from the nail bed. If they have an increased risk, low white count, if they have, say they soak their feet, they have diabetes, they may have chemotherapy and diabetes. This is a yeast infection that developed underneath her nail because there was a nice, warm, moist spot for that yeast to grow. So what do? Well, you have a loose nail and it's causing problems. You remove the nail. You just nip, nip, nip across it. Trim it down. That's going to be the $100 thing that you do for her. It takes a couple minutes, but that's really common. Sometimes it's not so obvious. It was very obvious to me when she walked through the door. Use your nose. Oops. Oh, that's the lady we saw earlier. Trauma into just from the nail. In fact, that was cellulitis. This is a lady who had claw toes. You can see all her clawing of her toes. She stubbed her toe. She also had diabetes, and she didn't know that she had an infection, but you can see the pus there. She had an infection just from stubbing her toe. And then we saw that one earlier. That's just from a nail that got some strep into there. This is another lady. She had just healed the ulcer on the other side, and you can see the ulcer here, but she's also got, see how red and puffy that is? And then, oops, let's go wrong side. And so you can also see, she bandaged her up, but you can see that redness there. So when you're doing your assessments, you're looking at this, looking for swelling and redness. They just have a lower immune system, so they're going to develop infections. And sometimes they develop them pretty rapidly if they have diabetes. This is just dry skin and fissured skin, but use your perception. This is a diabetic, and you can see his dark skin, but you can see that redness there. That was infected. So we got to keep these the skin moist and supple, and it's just going to be a reoccurring problem until you address the dryness. A very simple thing. Another infected toe. I think we saw that earlier. Now, this lady had dementia. She was not complaining about anything, but if you look, she's got, especially when compared to this one, she's got swelling, redness, the entire forefoot. That's going to develop into, well, it looks like a cellulitis. Here's a toe. She had diabetes. I see a lot of people with diabetes. But you can see how red it is underneath. That was just a little ulcer. She said she had for 3 weeks. But you can see from the front, she lost that toe. Skin integrity is so important. The area around the nail is called the paronychia. And sometimes it's just, it can be atopic. Atopic means when you're allergic easily. Blondes, light skin, they get allergic easily. Sometimes you can develop an sensitivity to soaps through the laundry detergent. It's 100 different things, but you can see how red that is around there. And it's swollen. That usually, unless they change things, change to a low allergy soap, just change a lot of different factors, what happens is it develops into, it's pulled away, that sterile matrix of the eponychium, the protection that separates the world from the inside is called the eponychium on this. Well, what happens is they end up, it's separated enough and chronically becomes a yeast infection at the base of their nail. That'll grow out, you treat it, and usually does fine if you change the offending factors. Elderly diabetics don't always have the cardinal signs of infection, which are heat, redness, warmth. They just always have that. And with cellulitis, they usually get, oftentimes, most of us get like a flu-like symptoms, chills, fever. They don't always get that. So I smelled something, and you got to trust your nose. And I couldn't really tell. This is an ulcer. She lost her toe a 1.5 years before, and that was a callus. It wasn't open. This is all dry. It wasn't open, but I'd seen her over a few months, and I think what she had then. So I smelled it, and I took out her insole, and it was a drain. She had drainage. I think she probably had tunneling from her surgery. It just hadn't healed, and it's been a 1.5 years, and it just didn't heal. Just a constant ooze. But trust your nose. People, elderly and diabetics, get melanoma. They get an increased risk. Some people think of melanoma as being on where the sun strikes most, in the shoulders, the head, the nose, the face. But acral melanoma is not, it's not common, but it happens. Some people, by the time it gets discovered, it's progressed because they just don't think you can get melanoma on your feet or your nails. But it's acral melanoma or subungual melanoma, under the nail melanoma. And it's just you use your A, B, C, D, E. Asymmetry. And this one, actually, we worried about. This was size. So asymmetry, A, B, border's fluffy, irregular. C is color, if it's more than 2 colors. D is diameter, if it's more than an eraser head. And that was more than an eraser head. So if anybody, and let's see, D, diameter, E is evolving. It's getting bigger. They tell you it's getting bigger. Not getting smaller. Ecchymosis gets smaller. Or family history is F. Any of those, they need to go to a dermatologist. This fits all of them. It's elliptical. It's abnormal shape. You can't tell, but it was 2 colors. It's certainly the size was big. So always keep that in mind. I just kind of threw that in. This is from, it says pitted keratolysis. It's from someone just not maceration. It's from maceration. And younger people get it oftentimes, especially boys who don't change their socks and shoes, and they get smelly feet. It's a bacterial infection of the foot. And you can't probably appreciate it, but you can see the pits in here. And this is just a bacterial infection, responds well to topical antibiotics. And dry, you got to get them dry, whatever the hygiene problem is. Dry skin, sometimes it's kind of hard to tell if it's dry or if it's this or that. Dry skin typically is linear, so you can see the lines. You can see the lines. This is flaky. It tends to be flaky. You can see the lines in that one. That's dry skin. Here's eczema, which you can see the plaques. This is a stechioeczema. You'll see it a lot in the elderly. I don't know, probably every 25 people you will see a stechioeczema. I see it a lot in men. It just looks like somebody took stucco and threw it on them. It's harmless. This, you see a lot too. You may not see it at Tiger Place, but it is, it's the eczema that has got an excreting pigment coming, and that's what the yellow is. Routine hygiene will improve that. This probably is psoriasis. You can see this here is a little yellowish there. Psoriasis is not uncommon. I love this picture. Okay, now I don't know if you can appreciate this, but this was a young guy who was 50, probably 50 years old. He had had a stab wound to his thigh. And this is what I'm looking at here. You see there? This is fine, and this is flaky, dry. Can you see the cell difference? There's a V. Do you guys see that? That's neuropathy. That's dryness of neuropathy. He had had a stab wound, and he had sensation here. He had no sensation here. It's from a stab wound to his thigh. And so, I mean, if you just saw this, you'd think, dryness. But we see in neuropathy, we see it, and we're going to learn a little bit more about neuropathy in a little bit. But sometimes it's hard to see why they have the dryness. There's a lot of different causes for dryness. It just could be skin irritants, could be vascular insufficiency, it could be hypothyroid. But it's always good to kind of, if you can, try to figure out what the cause is. And I just thought that was a good illustration of that neuropathic dryness. What could that be? You got the redness. You got maybe some swelling and some kind of excoriations in there. You got almost a similar pattern here. Any guesses? Well, first of all, it's symmetric, right? How many things occur? It's usually one side, right? If it's an infection, it's one side, right? Unless you're really unlucky. But it's a contact dermatitis. So we can get a contact dermatitis from our shoes. Lots of times, like with Crocs, you'll have little dots. You can see either a suntan or contact rubbers, glues. A lot of things can cause, but it's symmetric, and that's our kind of our indication that it's not always is redness infection. This is just contact dermatitis. So we need to talk about fungus, dermatophytic, skin bugs that are pathogenic. We see it all the time in the elderly. They may have just developed at the age of 70. But they don't have much circulation going down after 70. It's not as good. So they are going to develop more infections based on just not having good blood flow. We also see tinea pedis, moccasin tinea, and we're going to go through all of these because you probably will see them. So onychomycosis starts, these are just, I'm just going to throw them all up there. This is, oops, I'm sorry. I need to go back. Onychomycosis, nail fungus, starts because of the skin integrity has been damaged. So we normally have a sterile barrier between the outside and the inside. Our cuticle, everything is made, so, thank you so much, so that nothing gets in. But if you have nail looseness, say you stub your toe, you say you have a disease like psoriasis where it causes the nail to lift up, numerous ways, but lots of times it's trauma that gets carried over until we're older. So the fungus, which is everywhere, actually starts invading on the side, almost like 85% of the cases. And then it kind of goes this direction. Or, that's the distal. I forget the exact term for it, but anyway, it starts there. Or it can start on top so that you can get fungus on top. Oftentimes, that's the easiest one to treat, but if it's left there longer, then it will go in just like this, because this will eventually probably get loose. This is proximal fungus, and that oftentimes we see with people with HIV, very low immune systems. Unless there's been trauma, there is really low likelihood that anybody's going to get an infection there. It always starts up and out unless there's trauma. So that's a bad indicator. But as it develops, this hyperkeratotic gets thicker and thicker and thicker. And that's why when you go see some of those folks, they have hyperkeratosis and thick nails that was a centimeter thick sometimes. It's so thick. But it's because of that hyperkeratotic. So if you have something like this, or even yellow all the way over, and you don't see anything underneath, this is probably, if you stick your probe in there, it's probably more like lysis. It's the opacity where it's the nail has lifted up. But if it's nail fungus, it's almost always got that hyperkeratosis there, unless it's just on the surface. Does that make sense? And sometimes, if you I debride down, you can see how, you can see the purulence of it. Okay, then we have tinea pedis. You know, fungus is everywhere. People oftentimes, if we have hyperhidrosis, we're sweaty, we've got sweaty feet, poor hygiene, diabetes. We develop this peeling, fissuring, redness. This is all like athlete's foot. You can see maceration there. See where it's white? That's because it's it's just not getting dried enough. This is basically when two surfaces are together and it's sweaty, they develop irritation, and it just is red and fissured. But this is all looking like athlete's foot, tinea pedis. So we've got onychomycosis, nail, tinea pedis. It's, I think we've, oops, going the wrong way. Oh, and that's as a bacterial. So you start out probably as a tinea pedis and then went into a bacterial and secondary infection. Here's just plain maceration on its way to tinea pedis. Maceration, we don't want maceration in the web spaces. It leads to bad things. And there is an athlete's foot that's not in the web space. It's in you can see that peeling, and there's more of an angry-looking tinea pedis, almost like a bulb vesicular infection. Those are usually itchy. So onychomycosis is a reservoir that when this is a moccasin tinea, which means it's an athlete's foot that you're going to see. You usually see a lot in the elderly. It's a chronic fungus, and it's serpiginous. It's circular. See how this is not flaking. It's not dry. It's not linear. This is circular, and it's red. See, the base of it is all red. That's really common. That's kind of an obvious one. Sometimes they're a little bit more subtle, but if it's circular, that's term serpiginous meaning snake-like. That's a chronic yeast infection, which when somebody has low immunity or diabetes, having that there puts them at risk for cellulitis later on. Then we often see, they can reach their feet. Sometimes you might see in clinic someone that's called 2 feet, 1 hand. And that's where this is the same hand. And then you don't see the 2 feet, but I'll tell you. The idea is that they pick at their nail, they pick at their feet with 1 hand, and that hand, you develop a tinea manuum, which is hand. So they'll oftentimes so if you see somebody and they're picking at their nails, or don't let them, because you can develop it in your hands too. And then, or the fingernail, 2 feet, 1 hand. Or you can develop it into the, I see this a lot with the elderly, not uncommonly. You see that circular kind of red scaly thing that's like a ringworm. It's tinea corpus. Corpus means body, so it's a fungal infection of the body. The other thing that they can get is tinea curis. Tinea curis is where you've got your fungusy feet and nails, and you put your underwear on, and you drag that fungus up, and you get to develop it as like a jock itch kind of thing. So a fungus in the perineal area is the tinea curis. So fungus is a reservoir. We try our best to get rid of it, and by treatment or by better hygiene or Vicks Vapor Rub on their toenails, which I like. And here is another example of a chronic tinea. This is in memory care. I said, get 2 weeks, well, actually it was a month of antifungal on her feet, and look how much better it looks. I mean, seriously, it looks so much better. It's healthier. And what do you think that is? Any guesses? He stopped his methotrexate like a month or 2 before. Psoriasis. It looks like a yeast infection to me. It's dry. It just looks like an infection, but it's psoriasis. Okay, so we're going to talk about lower leg swelling. It's very common in the elderly. They have varicose veins, venous insufficiency, the edema. Oftentimes their leg is often, but not always, is bilateral, sometimes unilateral. Distinct from congestive heart failure, venous insufficiency, lower leg swelling from venous insufficiency goes away when you go to bed. You're no longer dependent. Then you get up and walk around. The edema gets worse throughout the day. It's a dependent edema. It is not innocuous. It is not, it's treated as innocuous in the medical clinics, but it's not. It can develop, and I don't have time to go through all the categories of lower extremity disease, but it can cause problems. It causes itching, swelling, and here, as you can see, it lights up really well, impetiginous impetigo, so a bacterial infection from scratching. So as nurses, we try to encourage them, if they can, wear compression stockings. And they usually can if you can feel their pulses. If you can feel their pulses, then they should be able to wear compression therapy. They don't always like it. And then using an emollient so they don't, because they get very itchy. But the itchiness causes problems. And that's an extreme example. I'm sorry. But here's their blood flow is very so I think we already talked about that. Here's another example of chronic venous insufficiency causing a problem. They get swelling. They get, and this you can kind of see. You see the brown there, hemosiderin staining. Hemosiderin staining is when you look at their legs and they have darkening. That's where the blood flow is slowly going through. And it's actually the iron pigments that are being deposited into the skin. The iron in the blood is being deposited, is staining the skin. It's called hemosiderin staining. It's a sign of lower extremity venous disease. So they a lot of times get superficial veins, and they get itchy. They scratch them, and this she had actually been hospitalized because the scratch. I just saw her like 3 weeks later, and it's still red, but it caused infection, cellulitis, based on her just scratching. So as nurses, just anticipatory guidance for someone with lower leg swelling, always try to remember to encourage them to, if they can, wear compression stockings. And there are other things you can do, like leg pumps, where the calf muscle gets, walking is good. Anything that strengthens the calf muscle will help the blood flow go back. And then using emollients, some kind of nice cream, Aveeno, there are lots of them, Gold Bond, lots of things, but they need to hydrate the skin. So another thing, type of, this is venous insufficiency as well. It's a little extreme, but I wanted to bring it to your attention. He'd already lost one leg from diabetes and obesity. When you have somebody with, and that is, that sometimes people say, what is that? So it's big toe, little toe, little toe, little toe. You got that, right? So, so what, as a nurse, when we look at that, do we just say, ugh, and go away? I mean, what do we need to tell him about this? How to prevent infection? What is he most at risk for? Maceration, right? All these are called interstices. All these interstices, skin on skin, moisture. That is all waiting for to get an infection, whether it's going from maceration because he can't dry or he doesn't dry, in between all those little spots. So as nurses, anticipatory guidance for someone who has any of these, but for him is maintain dryness in those spaces, whether it's web spaces or interstices because of venous insufficiency. It's like, this is like a non-infectious elephant, it's elephantitis. But it's venous and it's lymphedema. So dry, and zinc oxide is also, if you dry it really well, put zinc oxide in. That's a good way to dry it, but yeah. So lower extremity cellulitis is another thing that happens. It's where there's a break in the skin integrity, and then the skin flora, whether it's staph or strep, get into the skin and infect the area. So it could be, like the little lady with the toenail going in. That's a cellulitis, and it's just the toe or the foot. This we're talking about is the leg. The leg is red, swollen, warm. These things happen very quickly with people with diabetes, quickly. And so it's good to do anticipatory guidance with them. But red, swollen, warm, often flu-like symptoms, but if somebody's got a low immune system, diabetes in particular, they may not get those flu-like symptoms. And that's the risk factors. Lower extremity edema, web space maceration, swimmers. So you have these older ladies go 3 times a week to do swimming. They're in a constant wet state with their web spaces. They can't really reach their toes to dry them. And if they're healthy, obese, and swimming, they may not ever develop a lower extremity cellulitis, but you add these other host factors, and they certainly might. One of the biggest host factors is onychomycosis, which is nail fungus. It is a reservoir for fungus. So if you have it on the nails, it's going to go in between the web spaces. And what happens then? Well, you get maceration, peeling, skin breakdown. Then you get these other factors. Well, you get a staph and strep infection. They invade, and then you develop the lower extremity cellulitis. So we were just talking at the break how a lot of times people we hospitalize all the time, and they have a lower extremity cellulitis, and you look, and it's like, I don't see any breaks in the skin. And then they started looking, about 10 years ago, they started looking at the feet. And they found that people who have nail fungus are at higher risk for developing lower extremity cellulitis because it's a reservoir. It causes peeling and skin breakdown, fissures in the web spaces, which allow the normal strep and staph to invade and cause a lower extremity cellulitis, which is not a good thing to have. Sometimes people have to be hospitalized for it. It's often recurrent because the problems are not solved. But the main thing is trying to control the nail fungus and the web space maceration and infection. So we're moving on to ulceration and amputations in the elderly. So I always like to start out with the tragic rule of 50s. About 50% of persons over 60 have at least 2 risk factors for ulceration. And that may be diabetic foot ulceration, but it could be, from ischemia. Over 50% of amputations occur. It's actually 2/3. 2/3 of amputations occur in people over 60. I think that's really high. In the first 2 years after an amputation, you will have more than likely a second amputation. Somebody's not figuring out what's causing this. And that's really the nurses and the physician's responsibility. And sometimes it's a very behavioral thing. So, but we oftentimes don't educate them the way they need to be educated. And 5 years down after a major amputation, lower leg amputation, about half will not have survived. That's a pretty high statistic. So let's look at what causes. The number one cause of diabetic or any kind of ulceration and amputation is a sensory neuropathy. That's where the nerves are not functioning properly. And if it's because of high blood sugars or alcoholism, well, we're going to look at the causes. But it's number one predictor is sensory neuropathy. They can't feel as well with their foot. Then they have a deformity like a bunion, or we saw a lot of examples earlier where they have a callus on their toe, they develop an ulcer on their toe, and then they also have diminished blood flow. So that fits a lot of elderly people. There are over 100 causes of peripheral neuropathy. What I'm talking about is a symmetric neuropathy. It's very common in the elderly. What I'm talking about with a peripheral neuropathy is symmetric. It's not unilateral. It starts with the toes, the tip of the toes, and then it goes progressively to the shins. Once it gets to the shins, it'll then start in the fingertips. So it's a distal progressive neuropathy. And these are the most common causes that we see: diabetes, alcoholism, B12 folate deficiency. A lot of elderly have B12 folate deficiency. And then the list goes on. Sometimes we don't know what causes it. Like many of the people I see, I look at their foot and I say, "Can't you feel that?" And they say, "No." I don't know what kind of neuropathy they have. They have no sensation. They have diminished sensation. But it's very common in the elderly. Oftentimes not worked up. So you may not ever know why they have that neuropathy. Sometimes it's oftentimes overlooked. But what it does is it causes them not to be aware of any infection or pain or problem on their feet. And that's about, they can step, things like that. They can step on the tack. It's a tactile sensation. They touch and pain is diminished. They also have a diminished temperature sensation. So they can't judge proper bathing or even the spa. There have been so many eventual amputations, but ulcerations caused in spas because the person said, "No, I don't have a foot, my feet are fine." And because they don't feel them, their alarm system's gone. They don't feel they have a problem. They have no sensation. The temperature gets turned up, and they end up with an ulceration. It's very common. They have a lot of gait instability, and they may or may not have pain, like burning, itching, or not itching, burning, electric-like sensations. Those are paresthesias. Not everybody with diabetic peripheral neuropathy or alcoholic peripheral neuropathy have that. About 50% do not have any. So if you ask somebody if they have a problem, any problems with their feet, and they say no, how far have you gotten? You've gotten 50%. You may be lucky to, for them to say yes, but if they say no, you do not know if they actually do. So we have to take off their shoes and socks and do some sensation testing. Diabetes is increasing. It's increasing rapidly in the elderly. And the most common cause is obesity. It's diabetes type 2. Now 1 in 4 people have it who are 60 and over in long-term care. It's 1 in 3. In the next 10 years, 59% of elderly will have it. And as I said before, 2/3 of diabetic foot amputations occur in the elderly. So what do I want you to know about that? Well, one thing I want to talk about is pathologic callus, which we saw before. So you have, this is the tip of their toe. It's oftentimes at the tip of their toe because they're deformed toes. They're walking on pad. This has no protection. It's just bone underneath. So they're going to develop a callus. As we said before, that is a hemorrhagic callus, which is a pre-ulcerative lesion, which means if it keeps going, it's going to be an ulcer. So as soon as we see that, we debride it. I debrided it. You can see. I also didn't like the fact that his toes, you can't see this, but he has maceration. See how it's kind of white under there? So I put lamb's wool after I made sure he didn't have a wool allergy or lanolin. Lamb's wool is perfect. You can keep it in forever. If you don't take a bath with it, you can leave it in for a month. As long as it stays dry. It wicks away moisture. It's perfect. Here's another pathologic callus, a little bit more of a demonstration. The first time I saw him, he had his toe, but he was getting ready to have it amputated. So his callus is on his second toe, or excuse me, third toe. So then when he came back, it was amputated. The callus goes from the third toe to the second toe. The third toe is fine. Now it's moved to the second toe. Why? Because the whole way he walks is different. He's putting, this is kind of like hit up there, so you're not walking on it, right? He's just walking on that. So now the callus is on that side. Well, so what do? You take a $3 pad that looks like that, and you offload it. All calluses and ulcers have to be offloaded. Offloading by debriding it. This is where I debrided it. I took off all that dead skin with my file, and I applied this at this setting. I put it under here and offloaded it, and he came back a month later, and there's nothing there. It's no callus, no nothing. $3. But most of the time what happens is it gets ignored, and by the time you see him back 6 months later, they don't have three toes. I mean, they're amputated. These are amputated. It's just a common scenario. But offloading is what we do with calluses and ulcers. I offloaded it with callus debridement, then I offloaded it with a simple $3 instrument. But if you send it to the podiatrist, they can make a fancy, permanent one. This works great. Nursing interventions. Calluses, when you look at feet, you have to look everywhere. This is on the side. His bone, he had a bony protrusion there. That's what was underneath. And if that goes any more, much longer, that's going to be, amputated foot because you get a cellulitis. So what happens with those thick calluses? The thicker the callus, and it will keep getting thicker and thicker if they're wearing the same footwear. The thicker the callus, the more pressure that the skin cells are not sloughing off. They're compacting because they're trying to protect. And what happens, this is normal looking cells, but as the pressure goes farther and farther down, these are changing. This is becoming inflammatory. And it becomes inflammatory, it becomes hemorrhagic, and the next step is the ulcer. A callus is a herald to an ulcer. Okay? Ulcer is a herald to an amputation. And it happens quickly. So this is kind of a diagram of it. The callus forms, and then you get the hemorrhage, then you get skin breakdown, ulcer, and then it's so close to the bone here, it doesn't take long before you get osteomyelitis. You get a bone infection, osteomyelitis. Okay? It happens very quickly, especially with, and we have a lot of diabetic elders. A lot of diabetes and prediabetes don't even know they have diabetes. So got to kind of be in the back of your mind. Here's another one, walking on their toes. Plantar calluses are very common. They have to be offloaded. You can send those to the podiatrist. Arterial insufficiency. This is the peripheral artery disease, peripheral vascular disease. At its extreme, it's a chronic thing that really goes unnoticed in the medical visit. The pulses are low. We just keep going until something bigger happens. And what happens is, if you can see, what happens with more advanced peripheral artery disease is that when they put their feet down, it becomes ruberous. ruberous, red, red. You put their feet up, and it becomes pale, okay? If they start getting pale when they put their feet up, it's more of an acute ischemia. It's more like a surgical emergency. But that's what it looks like, dependent rubor with elevation pallor. And there you can see it's subtle, but it's there. See how red that is? That's not infection. It's all epenthera, and that is unilateral. It oftentimes is unilateral. But it's a chronic thing that becomes more serious in some. So your exam, so in the general exam, you're looking when you go to Tiger Place, you're watching them walk in. You're examining their gait. Do they have a neuropathic gait where they are kind of shuffling and have a wide-based gait? Do they have Parkinson's? They have a Parkinson's gait. Do they have a gait where they are trying to not walk on their foot, like an arthritic gait? It's a painful gait when they walk. So that gives you clues to what's going on with their feet. Then look at the general hygiene. You can often tell if people can't bathe or reach their feet. And so, that's an issue, which I don't have time to talk about. But general hygiene. If you're telling them they need to keep their web space clean and dry, and they can't reach their feet and they live alone, you've got to do something to help them, like put the lamb's wool. It's got to be something that you see where if they are capable of doing it. But so you're looking at general hygiene. You're looking from the knees down. You're comparing. You're looking for redness, warmth. You're looking for swelling, rash. All these things are indicators to an intervention that you should do. Just because it's the feet does not mean we can't do it. We don't cart feet off to the podiatrist. Those days are gone, right? Those days are gone. We have to deal with them ourselves. And we get the pulses and sensations. So the easiest way to check for sensation, if you're just doing an exam and you just want to know, do they have sensation, you can't ask them if they have sensation. You have to, because someone who has diminished sensation may say, yeah, I've got sensation, but that's because when you hit them, they feel it. But it's the subtle things. Protective sensation is what they need to have to be able to protect their feet. I don't know how that happens. I don't even know if I need it, but it'd be nice. So I think I'm just touching it a lot. So you can do it with monofilament, but that's a piece of equipment. You don't need a piece of equipment to do this exam. It's simple. They're not going to be looking at you. So what we're going to do is test the tip of their toes, right? And technically, this is the 1, 2, 3. This is the order that you do. But I mean, you don't have to do it in that order. That's just, if you do it for properly, it should be done this way. But you can test their sensation without even remembering how this goes. They can do it at home to test their own sensation. What you're doing is doing a feather-light touch. And it starts like this. 1, 2, 3, 4, 5, 6. So they can only miss 2. But your feather-light touch, they're not looking. If they miss more than 2, then they don't have protective sensation. They have neuropathy for whatever reason. If it's symmetric, then they have a symmetric peripheral neuropathy. If it's unilateral, it could be from a stroke. It could be from low back disease, spinal disease. But with diabetes, you can easily just feather-light touch it, and then 1 to 2 seconds, and then come up. That's a very easy way to tell if somebody has sensation. So we're looking at their pulse, or we're doing the vascular exam. We want to look at their pulses. If you have a stethoscope and you guys have taken physical assessment, right? Bruits, femoral bruits. If they have femoral bruits, that's an indication they have peripheral vascular disease. Their skin will be pale, thin, paper thin. They may or may not have hair. Their nails are brittle, thick, hypertrophic, and ridged. We talked about that dependent rubor and elevation pallor. their capillary refill will be decreased. And their dorsalis pedis, that's where if they have swelling, it's a little bit harder to feel, but you're going to check their dorsalis pedis. And if you can't feel it there, you can always check their posterior tibialis. They need to be symmetric. If they're not symmetric and one is decreased or absent, that's something of a referral. That means they have some ischemic disease. Okay. We're going to be on time. I'm trying, guys. Oh, I did it again. There was a delay that time, I swear. Oh, I could do that. All right, so nurses play a unique role, no matter what setting. Even Dr. Gardner, who is an endocrinologist, who's like, I don't know, he's 90 now. But with those type 1s, he would say, first thing he did when they came in for an exam for the type 1 diabetics, this juvenile onset, little infant, the first thing he did was check their feet. And he impressed upon the parents that the feet are very important. Then he went on to the other stuff. I don't know. Anyway, those days are gone. So this is foot care nurses in action. That's my office. You can't see a whole lot of it. But there's Paul, my DMP student. And there's doing assessments. In Canada, foot care nurses they're everywhere. They're into preventative foot care, and she's in a hospital doing foot care. There's me. I look like I'm stabbing the foot, but I'm really just smiling for the camera. Okay, so there's here's some of your students from community. They did their capstone. Elsie and Cameron. I don't know if you guys knew them. They were graduated last July, I think. Yeah. And so they're in my foot clinic, doing my free foot clinic with me. Elsie looks pretty happy there, doesn't she? She was really good. Whoops, how did that happen? Oh, well, I'm doing it on this one. That's what I'm supposed to. Okay. Have a high index suspension for the elderly. How this did. This one? High index. If they tell you their feet are fine, don't believe them. Never believe them. It's a foot care is a learned skill. You just develop it along the way. You just get better and better at it. And you hopefully have someone who can help you. And I will help you if you want. It's always patient-centered, always. We don't hurt them. We're mindful and try to give recommendations. Let's see. Oh, we also model hygiene. We just don't trim toenails. We model hygiene. Clean their foot, moisturize their foot. We always use sterile instruments and prevent cross-contamination. We always try to help them with their self-management, so you'll have to learn more after this, but at least try to help them with their needs. And we also make appropriate referrals. We don't just refer anybody. We look and see if they're at risk and make appropriate referrals. Don't delay. Like if you see an ulcer, they need to be offloaded immediately. Those are some of the instruments we use. It's pretty basic. That's my high-speed file. It goes 40,000 RPM, and it's amazing. I could never do the work that I do without it. So you guys are going to have to do this. So whoops. Which way? Back? Oh. Okay. So always, even nurses have been doing this forever. If I get to them or they come to me and want to learn how to do foot care, they always take the nipper and just put the whole nail practically in there. Always take, I'm talking millimeter, 1 to 2 millimeters, nips, small nips across. You always stabilize their toes because they do move. You have to stabilize. My hand is planted on their foot. It's planted. It's not in the air. It's planted. My fingers are moving the other toes away. I'm pushing this toward. Nothing can move. Okay, always stabilize. And you can see from the front how I'm just gripping that, because you can hurt somebody if you don't. And you just feel better when you just are stabilizing everything. And you also have to look what you're doing before you do it. You never know, like with this is it's a terrible picture, I'm sorry. But it is a hyponychium, the skin underneath the nail that is thickened. It's hypertrophied. And we do see that in COPDers. But if you're just going to start trimming in there, you can see that you've got to separate that skin out. And here, too, that nail was up against that. So you've got to separate that out. And it can take a little bit longer, but it does work. And here you've got to pull the skin back. You're always pulling the skin away from the nail. Like there. I mean, that's a subungual corn. That's a corn underneath the nail. And you have to cut around that. Anything under there you have to cut around. You can only trim nail. Sometimes people just start chopping. Okay, and just general recommendations, callus care, daily washing. I think we kind of did all these along the way. No soaking feet. Soaking feet is like a cesspool of dirtiness, and it also washes their natural oils away. So if people think that if they soak their feet, it'll be better. And it's okay therapeutically occasionally, but some people do it all the time. Oh, thank you. If you want to spend time with me, I'm happy to do it. I mentor people all the time.
Thank you.
Yes. It really is rewarding.
Thank you, everybody, for coming today.
Yes, thank you, guys.
And I will see you again, well, online maybe, but face-to-face in about 6 weeks. Okay?
Oh, that's sweet. Aw. Better get that. I don't know if you have to. I can take them to the football game. Take them to the football game.